This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2016, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is Disease Management and the Respiratory Therapist. Timothy Myers is a registered respiratory therapist, neonatal pediatric specialist, and fellow of the AARC. He is an associate executive director with the AARC and is an adjunct faculty professor with the Department of Pediatrics with Case Western Reserve University. Mr. Myers has no conflicts of interest related to this presentation. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis.
Today's topic is disease management and the respiratory therapist. One may ask, why are we talking about disease management in 2016? It was the buzzword of 1990s with healthcare reform during the Clinton administration. Well, we have reformed healthcare over those last 2 decades, but probably not to where it is, and changes are becoming faster and faster and more relevant in the healthcare setting today. And over the next 40 or 50 minutes, we'll take a little bit of look at healthcare reform, the changes that are impacting it, and what that means for the role of the respiratory therapist as we move forward. When we look at the current health system issues, healthcare costs in the U.S. are growing at a larger rate than employee wages or even the economy at large. When we look at the recent data from a few years ago, we are spending 17 to 20% of the gross national product in the United States is actually being spent in the healthcare setting. And I'm going to show you some relevancy on what healthcare has become in the U.S. at large, but it is becoming a bigger and bigger component of the average daily spend in the U.S. Despite that spend, in the U.S., our healthcare metrics, outcomes, and data are not significantly better than other industrialized nations that are spending a fraction of the cost that we are in healthcare today. And we still see preventative services are grossly underused, and that's, again, very key to this topic today about disease management. We know that patients with chronic diseases have low adherence to proven therapies, despite the fact that they're published in guidelines and there's a lot of research data to support that. And while we're not going to focus on medical errors or safety issues today, not a part of our talk, again, we know that is a big component of the need to have healthcare reform and changes in healthcare reform as we move forward. So I alluded to this slide that we're now looking at, which is really changes in the economy in the U.S. And it really is telling. If we look in the upper corner at the relevancy of where the economic engine, if you will, came from the U.S. at large or from even within an individual state back in 1990, we can see some very relevant trends. When we look at that greenish area, that is really manufacturing industry, if you will, that were the economic engine in those areas that are in that greenish color. When we look at the blue area, that is healthcare as an economic engine. And we can see in 1990 that just was non-existent in that chart. When we look at the orange bar, that is really kind of a retail or trade, if you will. That was the economic engine. And the green area that we really only see in Hawaii and Nevada in 1990 was really around the accommodation, food services, or entertainment, if you will. And those are big tourist areas. Shift forward to 2013, only about 20 to 25 years later, and we can see drastic changes in that coloring. Again, the areas in the greenish are industry manufacturing, if you will, that are really the economic engines. And we see that large area that was covered in 1990 is only really in the Midwest, upper Midwest, and a couple places in the South. When we look at that blue area, which was healthcare being the driving engine, that didn't exist in 1990, we can see that probably 60 to 70% of the United States in 2013 is actually relying on its economic engine based on healthcare. When we look at the orange bar, if you will, which was that retail or trade industry, there's still pockets as there were in 1990, but they're fewer, they're very isolated, they're kind of cohorted in the South for the most part, with the exception being Utah. And again, we still have a couple areas in green which are really based on tourism, if you will. Hawaii and Las Vegas, Nevada being the primary two states out west, as well as Wyoming now, if you will. But again, we can see the drastic change over the last 20 to 25 years in the economic engine in the U.S. and for most states now has moved from manufacturing or retail into the healthcare arena. As I stated earlier, despite spending 17 to 20% of the gross national product in the United States, our outcomes are not superior or above average compared to other industrialized nations when you look at the data. That, on top of the fact that healthcare is spiraling higher and higher in its cost on a daily basis as our folks with chronic diseases as well as acute episodes are paying more and more out of their pocket, there are a lot of things that require changes in healthcare. Listed on this slide are kind of the 4 key drivers of healthcare reform when you talk to the experts. We've already kind of touched upon it. There is a huge need in the United States right now to decrease the cost of healthcare. There's also a need to improve the quality of care that's being delivered. We also need to move from a model of quantity to one of quality, where effectiveness using outcomes measures, patient metrics, etc., are being more and more relevant and prevalent in today's world. And the other component, which has been a component for a long, long time, is improving access and resource allocation. Oftentimes, people think that this is those rural or isolated areas of a country, but that's not the case. There are a lot of studies out there to document when you look at patients in inner cities, large metropolitan areas, they have just as much of a problem accessing resources and allocation of health care in urban areas as those folks do in very rural areas in the United States. I like this slide because it shows kind of a number of areas, some of which we're going to touch upon here over the next 30 minutes or so, some that we're not going to cover in today's subject matter, are really kind of things that are impacting or things that are major changes in healthcare. We've talked about cost. Demographics, we have the baby boomers that are now starting to enter into their late 50s, early 60s, and 70s. These folks are actually now moving over from usually third-party payers to more Medicare-based types insurances, if you will. They're also seeing an increase in the prevalence of chronic conditions in this patient population. Access to care, as I've alluded to already, continues to be an ongoing problem, not just in those rural areas, but also in the urban or major metropolitan areas. Variation in clinical practice, an area that we're really not going to touch upon today, but this really talks about things like chronic diseases, be it diabetes, COPD, asthma in the respiratory world, if you will, that have pretty good documentation around practice guidelines. And in fact, most of them have moved to an evidence-based practice guideline, if you will. That still, there's a lot of variations in the care that's being provided that is adding costs but not necessarily improving quality. Insufficient use of information. We are in an information age with lots of technology, both in the acute care setting and in the post-acute care setting, and now even moving into patients' homes. We need to actually utilize that better to improve the days and quality of life of our patients with chronic respiratory diseases. We know that in the United States, we still have fragmented care that's very siloed, that we need to become better at integrating care across the entire continuum, especially for these patients with chronic conditions. Duplication, defensive, or medication waste is always going to be an issue that needs to be looked at and dealt with on a regular basis. I think respiratory care over its history of the last 30, 40 years has done a very nice job in eliminating waste, eliminating things that actually provide additional costs but maybe not inherent clinical value to the patients. IPPB being one that came out of the 70s, a major economic engine for respiratory care departments in hospital settings. But when you looked at the therapy compared to other therapies that were emerging at the time, it was not any better, and in some cases maybe even inferior. That led us to move away from IPPB-driven medication therapies. And again, practice adoption and innovation is always an issue that we're going to be looking at with that rapid growth in technology as we move forward. When you look at it from a federal perspective, from a state perspective, or even from a single hospital or a hospital system, cost reduction has become increasingly important to everybody. It's in the headlines of all trade magazines when you look at them around healthcare and how healthcare is going to be moving forward in the next 5 to 10 years, even in the next 18 months. The ability to reduce costs while still improving efficiencies and patient outcomes is critical in everybody's minds at this point in time. Now, this slide is an interesting slide. It's a couple years old, but it looks at economic data from hospitals in 2011, 2012, and 2013. And what it actually shows you are hospitals that are actually operating with negative operating margins, meaning they are losing money to take care of patients. And you can see that it was about 12% in 2011. As we moved across, there was a slight dip downward in 2012, but by 2013 it was up to almost 15% of the hospitals in the U.S. today were losing money to take care of patients. That's got to change. No business can operate that way. But again, when we try to reduce the cost, sometimes it impacts the quality or the effectiveness of the care we're providing. So it's the double-edged sword that healthcare administrators are dealing with on a daily basis. And even those hospitals that are successful, that do manage to make money, and again, let's remember, there are a lot of hospitals, most hospitals out there in the U.S. today are not-for-profits. So, if you end the day with zero revenues, expenses zeroing out, that may be an okay day, you're not losing money, but the negative component to that is that you're not able to reinvest in additional staff, new programs, capital equipment when you actually have no operating margin. If you look at that same data from 2011 to 2013, you can see that even hospitals that are successful are operating with about a 3% operating margin. So it's not a huge margin. What that does is drastically impact the ability to extend care, invest in technology, capital equipment investments, etc. So again, we all know that healthcare needs to be reformed and it needs to be looked at. Interesting enough, just last week, we can see in something I pulled from Modern Healthcare that in the city of New York, the mayor has actually tried to kick off what they refer to as a politically charged process for reforming city hospitals with a $2 billion plan. And the goal is to stabilize the New York City health and hospital finances. And again, why is this? Because it has to take place. Healthcare is becoming very, very expensive. Remember, this isn't in a rural area of the United States. The largest city in the U.S. is struggling and losing money in its hospital-based systems, and they need to reform it. This is, the city-run hospitals, if you will. Why? They're trying to transition the care from hospitals to the outpatient arena. And we'll come back and we'll show some data on that. But again, it's shifting those costs from those technology-laden, expensive, with high overhead areas, hospitals, into a more economically appropriate area, be it long-term care facilities, SNFs, the patient's own home even, trying to get them to a post-acute care environment. They also said that it's important because they get paid, and the way they're getting paid is increasingly based on the quality of care that they're providing rather than the quantity of procedures performed. So again, it's that value-based care that is becoming more and more focused to produce those high-quality outcomes. And in fact, we know that there are now penalties for adverse or negative outcomes for patients in the healthcare system. Here's an example of one of those, the CMS readmission penalties. Why was this? Well, it came out of a landmark paper published in the New England Journal of Medicine by Dr. Stephen Jenks that took a look at some of the chronic conditions, the high admissions with high readmission rates from hospital settings. And when they looked at that, and they looked at the cost to actually readmit those patients and take care of them a second time for the same type of condition, it was astronomically high. And in fact, this slide shows you the data of readmissions that really spurred on these readmission penalties. Within 30 days, where the kind of the penalty phase is currently set, almost 20% of the patients with chronic conditions in this look-see at this data were getting readmitted within 30 days. And in fact, when you look at those patients over 90 days, it was 1/3 of those patients that were getting readmitted within 90 days of a previous hospitalization. When you look in a full calendar year, it's over half of those patients that end up getting readmitted into the hospital setting. So we know the first round of penalties came out and it looked at congestive heart failure, it looked at pneumonia, and it looked at myocardial infarction because those were three of the biggest admission and readmission diagnoses that caused these penalties to go into place. But we know shortly thereafter it was followed by one. Not that pneumonia is not near and dear to the respiratory therapist's heart because it is a respiratory condition, but it comes from various different etiologies, if you will. But one very near and dear to our heart was COPD. It came in as the fourth chronic disease, if you will, or potential penalty. And what they did is they phased these in over a period of 3 years. The first year, it was a 1% penalty on your Medicare reimbursements. The second year, it increased to 2%. And the third year, it increased to 3%. Now, that doesn't sound like much, but here is a nice little picture, if you will, from Kaiser Permanente Health that really looked at what that could potentially mean in these readmission penalties. So, worst case scenario is 1% of your Medicare payment reduction across all DRGs in fiscal year 2013. So remember, that's not Medicare 1% for that specific disease, it's across all DRGs in Medicare. But let's follow through with their example. So if a hospital's total inpatient payments for Medicare totaled $50 million in fiscal year 2012, a 1% penalty of that $50 million would be $500,000. If it went on and it wasn't corrected into year 2, that $500,000 now became $1 million. And if it wasn't corrected in year 3 and it became a 3% penalty, it now is $1.5 million. That's based on a $50 million inpatient Medicare reimbursement. Most hospitals are not only hitting that $50 million, but double, tripling, and maybe quadrupling or more. And so you can see very quickly how those penalties start to build up from 1% to 2%, 3%, because it is on all DRG inpatient admissions. On top of that, here's an example. I get admitted with COPD, if you will. I actually get discharged. 3 weeks later, I'm walking outside to get the mail and I slip on an ice patch in my driveway. I fall and fracture my femur. I get readmitted. That would actually, because I would have a chronic condition of COPD as a secondary diagnosis, even though I'm there for a femur fracture, would get me readmitted for surgery or whatever the case may be. That is included in the penalties because it is all cause on the readmission. So you can quickly see how this became very problematic. A lot of folks tried to address this very quickly. And one of the things that they try to do is start to implement some disease management processes in the hospital setting as opposed to in the outpatient arena. And a lot of good work has been done, a lot of that by respiratory therapists and respiratory therapy departments, along with their nursing and physician colleagues, to really look at respiratory conditions, to try to stabilize these patients in the hospital, determine what is the good or appropriate transition area to send them to after discharge. Subacute care, long-term care, skilled nursing facilities, or if they're ready, even into their own homes, to actually address the ability to continue to manage these patients across that continuum in a wellness, prevention, and rehabilitation state to prevent some of these readmissions. That's a problem because in the U.S. we do have fragmented care. We have this silo mentality across the continuum. I mean, let's think about it in a very realistic setting in the hospital-based area. Oftentimes we have patients with asthma or COPD that have exacerbations, and if they're slightly mild or moderate in nature, they come to the emergency room, they get treated, and they get sent home. We don't necessarily follow them up. We don't make sure they get their prescriptions filled. We don't necessarily make sure they go back to see their primary care physician or their pulmonologist. We take care of the acute episode. We send them back out into the world to hopefully prosper. Not always the case. We also have that problem in the acute care setting. So we are very fragmented. We don't address that patient's needs, wellness prevention or remediation, rehabilitation, whatever the case is, across that continuum of care. Inconsistent patient education also becomes a problem. And it becomes a problem in a lot of respiratory diseases that are chronic in nature with stability, mild or moderate flares, and very severe exacerbations. But we don't do a very good job of providing patient education. So I'll give you one of my own examples. A number of years ago in Rainbow Babies and Children's Hospital, a pediatric hospital that I worked at, pediatric asthma was a huge problem for us, and it's still a problem in a lot of children's hospitals today. At the time that we started to take a closer look at this and decide that we had to develop some clinical practice guidelines, protocols, if you will, and then actually turn into a full-fledged disease management program, we realized that we had numerous, and when I say numerous, I'm talking 100, 200 people, providing asthma education just in time to meet that patient's need. What do I mean by just in time? Usually that meant 10 to 15 minutes before they walked out the door. We're trying to teach them things about asthma, their medications, follow-up, etc. Not good timing. They're trying to make sure they've got their ride. They're trying to make sure they've got all their personal belongings that they brought to the hospital. Worried about getting back to school, notes to get back to school, back to work, whatever the case may be. Very divided attention to try to do true education. But we do it based on exacerbations, not along the continuum of wellness into exacerbations. We really try to do it in the wrong setting, if you will. We also know that there are minimal communication amongst healthcare providers. I gave you the example of emergency room. Again, not necessarily the job of an emergency room physician to provide chronic disease management to patients that show up on their doorstep. But there needs to be some kind of communication and follow-up to make sure those patients are getting back into the healthcare setting, that they're getting prescriptions filled, that they're getting back to see their primary care physicians or their specialty practitioner. We know that at-risk patients are very at risk, obviously. It's kind of a catch-22 at discharge if they don't receive the proper follow-up. And we saw that. That's the whole rationale and reason behind readmission penalties, if you will. We know there's prescription issues. How many times have you actually had a patient that's come in, you've done education because they're going home on this certain type of medication, be it a combo product given by a discus, maybe they're going to have their rescue medication with an MDI, and when they go out to their local pharmacy where their coverage is provided, what we prescribed in the hospital setting is not actually on formulary with their healthcare plan. So the pharmacist has to react on the fly to change it to get comparable medications to that patient at the appropriate dose. But maybe now it's not a discus for that combo inhaled corticosteroid LABA product. It's now another MDI. And that's something completely different than what we actually started out in the hospital or what we trained them or taught them on. So again, we have this problem. Again, it's that silo mentality across the continuum. There's also a lot of data that shows that when patients get discharged, even though a lot of times they walk out the door with a follow-up visit scheduled in the next 3 to 5 days, that they start to feel a little bit better. They don't think that their asthma is an ongoing issue, so they don't go back and follow up, or they can't get to their appointment. We're back to this access issue, if you will, becoming very, very problematic in delivering healthcare consistency, care, education across that continuum. And we've already kind of talked about misappropriation of the emergency room. So again, another slide that I recently found in doing some reading and staying abreast on healthcare reform. And this really kind of looks at America's healthcare rankings report from the United Health Foundation. And again, I'm not really trying to focus on what states are better than other states, but what it actually I thought was intriguing from this graphic that I'm showing is that the first one talks about healthcare access. Now, the way this is set up for both of these maps, if you will, is the lighter the shading means that they're in the top quartile. They're top 25%, they're doing very, very well. And as you get darker in the colors, for example, healthcare access being in blue, as you get to the very deep, darker blue, there are issues around access. Now again, looking at this graph in the United States here, you can see that it's not necessarily the rural areas that are having the most difficulty in getting access, although there are many of them there. It's areas that have major metropolitan areas that also have access issues. Again, because patients can't get from one side of town to the other. They don't have transportation, they can't afford public transportation, or it doesn't exist. There's numerous reasons when this has been looked at and studied. The issue is that health care access is still a problem. Some states are handling it a little bit better than others, some not so well. Shifting to the other side of this graphic really talks about chronic disease prevention, and this is where we're going with the rest of this talk around disease management and the role of the respiratory therapist. Again, same orientation. The lighter the shading of the yellow in this chronic disease prevention, top quartile, 25% of the upper ranking states that are doing a pretty good job. And again, some of those have programs in their Medicaid and that are addressing this, or third-party payers looking at disease prevention, chronic disease management, if you will. And as you get darker in those yellow tones, almost getting more orangish, those are states that are struggling with chronic disease prevention. And you can see that it's not geographically restricted or certain areas that are doing better than others. It's very diverse in how it is laid out and how the data is coming in, that we have problems with not only access, but chronic disease prevention or disease management, as we're here to look at. This is just a different look at it from a graphic standpoint. If you are actually to the right hand of the bar graphs, that means you're actually above average and doing fairly well. If your bar graph is moving more to the left, that means that you're actually probably a little bit weaker in those areas. And it's broken out into those same areas, blue being healthcare access, the yellow or orange being chronic disease prevention. The other one that's thrown into this graph that wasn't shown on the previous slide deals with immunization. So again, we know that potentially can lead to other issues of allergy and asthma and etc. But again, we can see that it's very dispersed across the U.S. It's not geographically restricted in any specific areas. So we've talked a lot about chronic conditions, access to care, things that are adding cost to the system. What are those things? We need to identify those things first and foremost before we can talk about disease management. Which chronic conditions, if you will, are really accounting for this rapid rise in healthcare spending? And this is from a publication by Thorpe and colleagues that was published a few years back in Health Affairs. And this is older data. It's looking at about a 10-year period from 1987 to 2000. The interesting thing is that while there have been maybe some adjustments in those top 10, top 12, if you will, the same diseases are still there. If you look at them, they may have shifted positions. Again, what I just want to do is highlight the areas that really are near and dear to respiratory therapists. And you can see them outlined here. Pulmonary conditions. So when they talk about pulmonary conditions, they're really talking about things like asthma, COPD, cystic fibrosis, pulmonary fibrosis. They're all kind of lumped into a category. And you can see it's number 2nd in the top 15 most costly medical conditions accounted for in this 13-year period, if you will. A little bit lower down in that second red box is pneumonia. And again, pneumonia comes from a variety of etiologies. Can be either inpatient, hospital-acquired, etc. But what this slide actually highlights is that when you look at this 13-year period and the cost associated with those two respiratory type conditions, that for respiratory conditions, pulmonary conditions, they had a 1.5% increase in prevalence in that decade. Not a big increase, but there still was an increase, 1.5 times increase. But it came at 3 times the cost. So despite the fact that the prevalence went up slightly, the cost to treat those pulmonary conditions rise twofold faster. Even looking at pneumonia across that 10-year, 13-year period, while the prevalence was flat, it cost twice as much to take care of those patients with pneumonia. So this was just the beginning, if you will, of the fact that healthcare costs are rising, and you can't attribute it to more patients being sick, more chronic diseases, etc. It was an increased cost with a relatively flat or a lower increase in prevalence than that associated with the cost. When you start to break those out as to individual diagnoses, if you will, you can see now that asthma and COPD fall within the top 10. And that's probably not a surprise to most respiratory therapists. They are chronic respiratory diseases that account for a large cost not only in the inpatient factor or setting, but also in the outpatient setting, if you will. So they are two very, very prevalent diseases, and they are two very, very costly diseases. If we look at asthma, there's probably estimates out there now in the U.S. that probably 20 to 24 million Americans have the disease of asthma. Probably about a third of those are children. They identify children as those being 17 years of age or younger. So it is a very prevalent disease in the U.S. Probably you can't find one person that you know that doesn't either have asthma or know somebody that has asthma in the United States today. Chronic obstructive pulmonary disease, I think we're still on the front edge. It's kind of like that iceberg. It's the tip of the iceberg. We know that there's about 12 million diagnosed COPD patients in the United States, but there are estimates that it could be twice to 3 times that amount that have the disease that just haven't been diagnosed. So again, we're talking about potentially another 24 to 30 million patients. So when you combine those two diseases together, asthma and COPD, and not really talking about that overlap syndrome, if you will, but asthma and COPD probably account for about 60 million Americans in the U.S. today with one or the other of those two conditions. It is becoming an increased burden of cost in healthcare. By different estimates, 70 to 75% of all healthcare costs in the U.S. today are being based on chronic conditions. Now, that's not just respiratory conditions, that's all chronic conditions, be it cardiac, renal, GI, things like diabetes, etc. 70 to 75%, 3 out of every $4 of healthcare is spent on a patient with chronic conditions. The interesting component is in that analysis, they feel that the majority of those costs for those conditions are in one way or another avoidable. So patients that aren't taking their medications, or patients that are going to the emergency room inappropriately, or patients that aren't able to self-manage that end up in the emergency room and then hospitalized, potentially are looked at as potential avoidable costs. They feel that with these chronic conditions, that at least some of these conditions and the costs associated with are part influenced by behavior. And that gets into the whole adherence, non-compliance thing, and we'll touch briefly on that. That's a whole talk for a different day. But again, these are potentially conditions where those costs can be somewhat remediated or reduced based on behavior changes. And we know that a lot of these diseases are out there, that proper treatment can control the conditions more cheaply than treatment in the acute care phase. Not a big surprise. When you look at the increasing prevalence of chronic disease in the U.S., it's interesting. And I've highlighted some of that on this slide for you. It states that about 50% of the Americans in the U.S. today live with some type of chronic condition. 1 out of every 2 of U.S. citizens have a chronic condition. Now, the interesting component is you take that 50% that have a chronic condition, half of those people, 50% of the 50%, actually have not one condition, but multiple conditions. Congestive heart failure, diabetes, COPD, diabetes, congestive heart failure, COPD, asthma, allergy. Again, there's any combination that you could probably think of. So that estimates that probably 25% to 33% of U.S. citizens have multiple chronic conditions. So now you can quickly see how the cost is exponentially higher for those patients. Interesting enough, 54% of chronic adult patients receive the recommended care. We know that we have COPD guidelines. We know that we have asthma guidelines. They exist for diabetes and other chronic conditions. But the interesting thing is in multiple study after multiple study and meta-analysis, that only a little over half of those patients received the recommended care as outlined either by the experts or in an evidence-based fashion. The other component falls on maybe a little bit of the patient's shoulders, that 60% of patients are non-compliant. I don't like to highlight that or focus on that because sometimes we don't give patients the tools or the resources to make them good patients, to make them compliant, to make them adherent to their medication regimen. We make it difficult for them. But the fact is that 60% of the patients out there with chronic conditions don't follow their medication regimen the way they should. All right, we're all guilty, right? Let's think about it. Who has actually got prescribed a 10-day course of antibiotics? You take that, you get your prescription filled, you go home, you take that first dose, you take it the second day, and then the antibiotics kick in about 48 to 72 hours, and you're starting to feel a little bit better, and by day 7 or 8, you're feeling great, you're back to snuff, and you say, you know what, I don't need to take those last 2 or 3 doses, and you stop doing it. That is human nature. The problem is the U.S. healthcare system is not prepared to meet the patient needs in its current silo mentality system to deal with those education and behavior issues. And that model is not sustainable, as we've seen from the healthcare cost. So I always speculated, where did these anecdotal thoughts or data come from? 50% of the patients have chronic conditions, 50% of those have multiple conditions. And I never really saw data until a few months ago in a publication that came out from AHRQ. And it looked at a distribution of adult population and the distribution of those expenditures by the number of treated chronic conditions. And lo and behold, when you look at this, it's very interesting. If you look at the bar graph on the left, you can see the U.S. population, 18% or older, and in the purple area at the bottom is those patients have no chronic condition. It's about 55%, meaning the flip side is blue, gray, and yellow account for 45% of the U.S. population, 18 or above, actually have at least one, if not multiple chronic conditions. And then they break that out into those percentages when you look at it in how their cost or healthcare is expended. And you can see that 45% identified in the first bar graph, when you move to the second bar graph, now all of a sudden count for 78% of healthcare costs. So again, that data is very accurate. 1 out of every 2 patients have a chronic condition. Half of those patients have multiple chronic conditions, and they account for about 70 to 75% of the cost. It is highlighted here in this publication and expenditure data from AHRQ that was published on the population in 2012, so just a few years ago. Remember, data like this is always going to be a year or 2 behind, if not a few years more than that, because you need to correlate it and analyze it and those types of things. So this is some of the most recent data. This was just published a few months ago. So what's that mean for all of us? Healthcare reform needs to take place. It's very, very expensive. Healthcare administrators, politicians, everybody in the world, or at least in the U.S., knows that we need to reform healthcare and we need to make it better. How do we do that? Well, today we're going to focus on those patients with chronic conditions. And when you talk to healthcare administrators, they say this. They want clinicians in the acute care setting and in their continuum of care, because we know a lot of these systems now have physicians' practices, acute care facilities, emergency rooms, pharmacies, home care. They're trying to bridge across that continuum of care to reduce their at-risk with insurers and the feds. They want clinicians that have skills as patient educators with a perspective on healthcare outside their technical areas. So that means a respiratory therapist can't just worry about ventilators, oxygen, aerosol, airway clearance, that you need to not only have that technology and technical expertise, but you need to have a broader-based knowledge, skill set, and attributes that really allow you to look at patient education and managing these patients with chronic disease across the continuum. And they also want clinicians that come with strategies for reducing healthcare costs by either increasing their productivity, consolidating of their service lines, or a greater emphasis on wellness are needed. Finally, we're going to talk about wellness and prevention, and that leads us into disease management, if you will. Disease management, it's a change in the mindset. care that will impact the control of the disease and symptoms as well as improve upon the quality of life of those patients. It moves from that mandated treatment of the patient, directed care across the entire continuum. We know in the past it's been much easier to treat and give therapy than to educate and communicate with patients. That's no longer acceptable. We have to educate, communicate, as well as treat those patients to actually meet the growing needs of patients with chronic conditions as well as the healthcare system at large. I think this is a nice graphic because it really talks about where we're going, which in the past was kind of the cost-based, quantity-based care to this more value-based, quality-based care. And again, what it shows is down at the end is the area that we need to be working on. Healthy, low-risk patients don't need much intervention, that annual visit to their primary care physician. As we start to move up that continuum, we see patients that are at risk, patients that are high risk, and then those patients with chronic conditions. And those are the patients that actually really, as we have seen now, ramp up the cost. And we need to work with these patients through wellness and disease wherever they're at on that continuum, because probably all of us are on that continuum. And as we get older, we start to shift, if you will, to the right of that continuum with a chronic condition, we're at risk, at a higher risk, etc. So what is disease management? Well, while it's 2016, I still like this definition from when disease management first became a buzzword in the mid-90s. And this is from Barry Make, a pulmonologist, that was published in our own journal, Respiratory Care, in 1994, because I like the way Dr. Make identified this. He said disease management is a comprehensive and coordinated system of care that deals with the disease state rather than just the acute episode. So we're dealing with the disease state or that patient as an individual. And its components include prevention, treatment, patient tracking, and follow-up. We're covering that patient across the continuum of care, not just treating them in an acute care setting, but we're trying to prevent them from ever being in there or developing these conditions. We're treating them when they get them and have exacerbations, but we're tracking them and following up and monitoring them post-exacerbation or even in a wellness component with a chronic disease, if you will. What are the goals of disease management? We want to reduce the rate of disease progression. Well, easier said than done. We just talked about asthma, although it's a much slower increase in prevalence, is still going up. COPD, 12 million patients diagnosed with COPD, potentially twice to 3 times as many of those patients are out there that just haven't been diagnosed. But again, once a patient's diagnosed, proper treatment, self-management, and good behaviors that are produced in some of those evidence-based guidelines show that you could potentially slow that disease prevention progression as well as acute exacerbations. We want to eliminate or reduce those risk factors that those patients have. That could be allergen exposure to the asthmatic. That could be getting our COPD patients to stop smoking, smoking prevention, smoking cessation in patients that have yet to develop chronic lung diseases, potentially as a risk reduction. We want to sustain control of those symptoms. Again, symptom management, self-management, wellness prevention in patients that have chronic disease, if you will. We want to reduce that recidivism or those readmissions, rehospitalizations, which has now become a punitive thing from a reimbursement standpoint. But more importantly, we want to facilitate activity daily living in most settings, and we want a quality of life for our patients with respiratory conditions and these chronic respiratory conditions. We want them to lead normal, active lives. We don't want to hear that Johnny can't play football or Johnny can't go out at recess or take gym because Johnny has asthma. That's just not acceptable. We have good medications. We know good behaviors. We know good self-management practices, as well as those that are helped by the healthcare team, can help allow patients to do activities of daily living. And again, we want to enhance the quality and duration of life ultimately for these patients, and we're seeing that with everything. We know that in the U.S. population, over the last 100 years that we've moved from patients dying maybe in their 40s and 50s to now in their 70s and potentially their 80s. And again, the longer patients live, the more likelihood they are to develop chronic conditions. So what are the key components of disease management? Well, It is identifying the population at risk. That's easy for us in a respiratory world. Those are the COPD patients, the asthma patients, pulmonary fibrosis, cystic fibrosis. And then trying to incorporate evidence-based practice guidelines, be it in the hospital setting, in the emergency room setting, in the patient's own home. There are good documented guidelines out there for most respiratory conditions. The big ones, asthma, COPD, cystic fibrosis, that lead us to do things that are very high in evidence of being good care for those patients. Hopefully we'll get there someday with pulmonary fibrosis and pulmonary hypertension, still areas that are currently being looked at and researched, and a lot of research dollars from pharmaceutical companies going in to potential treatment options for them. Not quite there as we are with the other three. Collaborative practice, the team approach, if you will. It's just not the physician and the patient. There is a support network that is both from the patient's family as well as the healthcare team that needs to collaborate and work on this across that entire continuum of care. The next one is very important, patient self-management education and self-management behaviors and practices. We can do everything in the world where a patient's in a hospital, in the emergency room, or in a healthcare setting. But ultimately, at the end of the day, the patient has to go into the home and take those resources and those tools and actually be able to practice good self-management behaviors. We need to get better at process and outcomes measures and looking at these patients across the continuum of care and tracking them and monitoring them and understanding what works and what doesn't work and when to change the game plan, if you will. And again, routine feedback, be it amongst the healthcare team or with the patient and the healthcare team, is also very important. I like this quote from Eric Larson, who is a healthcare economist, who touched upon this and said, rather than uncoordinated episodic care, we need to offer care that is well organized, coordinated, integrated, and characterized by effective communication that is based on a continuous healing relationship. So it's not the proverbial treat 'em and street 'em that we practice with many acute exacerbations of respiratory patients over the years. It's a continuous healing relationship across the entire continuum of care that will allow us to move the outcomes to where we want to go. We know at the ARC and in other respiratory organizations that this is vitally important, and it's not like we're just catching wind of this 20 years later. We've been on this for a long time. Here is actually a portion of a publication from Respiratory Care in 2010. It was part of the 2015 Consensus Conference that was a series of three conferences looking at where the profession of respiratory care was going and where it needed to be by 2015 and beyond. And this kind of came out of the second go-around, or the second Consensus Conference, looking at competency areas of graduating therapists and even those that are practicing in the clinical setting today. And there were about 7 or 8 different areas identified in those competencies, but you can see that this area, number 2, identified by that group of experts, was disease management. So again, we were on this and we've been on this for almost 2 to 3 decades. They identified disease management with a specific set of skill sets and competencies in 2 areas: chronic disease management, ambulatory outpatient, and acute disease management in the inpatient setting. Now, why is that a differentiation? Because there's different strategies in both those areas. And the problem we have right now in today's world is 75% of the respiratory therapists practice in that acute disease management area, in the hospital-based setting, in the emergency room. Then only about 25% of practicing licensed therapists out there are in some other area of care. And that could even include education. But we don't have enough therapists in home care and post-acute care settings to allow us to do this chronic disease management of patients with respiratory conditions as well as we should. But it's a good paper. Pull it, look at the areas on disease management and what those competencies need to be. This is a paper from a few years ago as well. It was published as part of a journal conference looking at the management of asthma as a big entity. And there was a paper of that paper from that journal conference of about 10 or 12 lectures, 10 or 12 papers that came out of it as well, that's specifically focused on asthma disease management and the respiratory therapist. So again, about 8 years ago, we're still on this, and it identified very key areas that the respiratory therapist could make an impact. And in fact, it actually highlighted some smaller case studies to some larger studies of where disease management worked very, very well by respiratory therapists. And again, this was a publication that the AARC was very, very proud of back in the late 1990s. It was done with the federal government, and it was the first booklet, document, whatever you want to refer to it as, that was published for a specific healthcare entity, and it was titled Making a Difference in the Management of Asthma, a Guide for Respiratory Therapists. So again, this was an older publication, focused pretty much around asthma, because asthma was in its heyday in the 90s and the early part of the 21st century. COPD has quickly caught up over the last 5 to 10, 15 years. But it really focused on programs across the entire continuum of care, in the hospital setting, in the emergency room, home care, where respiratory therapists were providing disease management and actually producing very good and documented positive outcomes. So again, we've been on disease management from its inception. We just haven't gravitated enough from the acute care setting into the disease management in the chronic setting. So what are recognized methods to improve health and reduce cost? Education of patients, professionals, and each other is an essential skill for the respiratory therapist. We've already talked about the problems with admissions and readmissions with chronic respiratory conditions, and we have an ability to make an impact there. Protocolized care, or if there's not protocols in an evidence-based fashion, best practices. And again, I think it's something we've done very, very well over the last 2 or 3 decades as a profession. Disease management and self-management. Disease management from clinician to patient, teaching that skill set and that knowledge that the patients need to go home and do self-management is very, very important. Preventative care. We've got to get into wellness and prevention. We cannot sit on the sides and treat acute exacerbations, or healthcare and healthcare reform will pass the profession of respiratory care by if we don't get on the wellness and prevention bandwagon very, very soon. And to do that, we have to get outside the hospital walls. And again, risk factor modulation is always very, very important. Even in the guidelines, the evidence-based guidelines that were produced by the NHLBI NAEPP committee says that asthma self-management is essential to provide patients with skills necessary to control asthma and improve outcomes. And they go in and list 4 key points with evidence level graded out as a B on a scale of A to D, I believe is how they graded these out at the time. B being very, very important, maybe not absolutely solid evidence as a level A evidence would provide, but very good mechanisms implementing multidimensional interactive clinician education in asthma care. Consider participation in programs to enhance skills in communicating with patients. Encourage and develop the use of acute care pathways to manage acute asthma, but you could flip it to the other side and say the importance of using treatment plans, written treatment plans in the home setting to allow patients to self-manage those exacerbations in a milder form in that area. And again, develop and evaluate system-based interventions to support clinical decision-making. Again, a disease management model that ultimately, hopefully, transitions to patient self-management. Now, this is an interesting study, and I often laugh when it comes up because it's from 1980. And so somebody may say, geez, what are you showing a slide that was from 1980s in the Annals of Internal Medicine in 2016? Well, what I want to show you is that this was an interesting section of a larger study, but it asked patients if they wanted to be more involved in decisions about their treatment. Patient self-management, so it's right in our kind of strike zone here as we talk. And actually you can see that those that were classified maybe as geriatrics over 60 years of age in 1980, about half of them wanted to be involved. Most of them said, just tell me, doc, what you want me to do and I'll go and do it. And I kind of laugh because I kind of look at that as being my parents' generation, baby boomers, or maybe slightly before the baby boomers, if you will. Doc, just tell me what it is that I need to do and I'll try my best to do it. When you looked at the next subset of 20 years under them, 40 to 60 years old, it up to about 6 to 7 out of 10 patients said, I want to be more involved. And then when you looked at those patients in 1980 under the age of 40 that said, I absolutely want and need to be involved in my treatment and care, almost 90% of those patients said that. Rapid speed ahead. Those under age 40 in 1980 are now our baby boomers in their 70s. And it'd be interesting to see this study repeated to see if 90% still say, I want to be actively involved in the decisions about my treatment. And the fact is if it's probably still there, you can bet that those percentages are there and higher for those younger than them. So again, it's not that patients don't want to be involved or don't want to have decisions in their treatment. They want to be taught. They want to learn self-management concepts and behaviors and be an active, vital role. This is an interesting component because oftentimes and I'm not going to spend a lot of time here, but we often label patients as, well, that patient is not fixable. They just are not going to be adherent with their therapy. And that is problematic because non-adherence has various dimensions such as admissions, intentional interruption, or spontaneous change in dosing or refill rates that have a variety of impact and factors. It's unclear to what extent these different components of non-adherence are correlated. Here is actually a little graphic that came from the World Health Organization that talked about adherence to long-term therapies and evidence for action. And again, it's about a decade old, but it says there are health system factors that potentially play a role. There are social and economic factors. If I can't afford to fill my prescriptions, then I'm not going to actually be adherent to my therapies. There are condition-related factors. My disease is getting worse. I'm going from a mild to a moderate to a severe to maybe end stage. There are therapy-related factors. The therapy I'm being prescribed doesn't work, or I need a stronger dose, or it's giving me side effects that are worse than the disease itself. And there are patient-related factors. I got a life, I got a job, I got kids, I've got responsibilities. I can't sit and take a nebulizer treatment 4 times a day for 15 or 20 minutes. That just doesn't work. So again, you can see a number of factors revolving around this patient in this graphic that all could potentially have an impact on their adherence to their therapy. And we have to look through each and every one of these areas to identify if these are potential barriers to that patient being adherent. I don't think any patient doesn't want to follow a physician's direction, I don't want to say orders, but direction or their treatment plan, but a lot of these factors get in the way. This is a very interesting study that looks a little bit at adherence and compliance. And what it does is it basically says this is a relationship between instruction of inhalation therapy and the medication adherence and health status in chronic obstructive pulmonary disease. And what they did is they actually took 2 groups. A group that was what they called the control group, which is the way the process had always been done, versus a group that not only got education, but they got follow-up at each subsequent visit. And you can see that those that were in the repeated instruction group had much better outcomes. They had an improvement in their quality of life. They had an improvement in the ability to take their medications. They had an improvement in their ability to reduce their symptoms. Overall, it worked very, very well, and it was statistically significant. So you can see this, that their symptoms went down, their self-reported quality of life improved, and they were able to be more compliant because they now knew what the medications were, they knew how to take them, and they actually received positive feedback when they were doing it well, or constructive feedback when things weren't going as well. And so we often see this. I often like to give an anecdotal sometime, and this is more personal than it is professional, but having a father with COPD, first time he was prescribed a controller medication, I went out to visit him about 2 or 3 weeks afterwards, and I said, how's it going? He goes, I stopped taking the medication. And I said, well, why did you stop taking the medication? He goes, it didn't work. And I said, what do you mean it didn't work? He said, well, I don't feel anything when I take it. I don't feel any different in the afternoons or the next day than when I started taking it. And I said, because it is doing its job. It's a medication that is there to prevent symptoms from occurring. But the fact was that he had been so trained, and his behaviors had been trained to respond to exacerbations and airflow obstruction. I take my rescue inhaler or my relief medication, whatever you want to call them, and I actually feel better in 10 or 15 minutes. I dilate my airways, I'm able to breathe more comfortable, I'm less short of breath. The medication works, where patients think the chronic medications don't work per se. So the take-home points from kind of really the adherence, and again, like I said, this is a whole nother subject, a whole nother talk, but long-term adherence is difficult. It requires realistic expectations from a healthcare perspective as well as a patient perspective. It really involves a therapeutic relationship. You just can't do one and done. You can't teach it once and then forget it. It has to be reinforced at each and every visit across the continuum of care, across that patient's life with that chronic condition. education is important. As we alluded to really at the beginning, that a lot of chronic conditions have a lot of behavior influence in how they're managed over the course of a life or the course of symptoms, and that education is one way to potentially remediate these or correct these. Side effect management is also important. I worked in a pediatric setting, and it was always important for us to sit down and say, these are the good things that the medication are going to do. These are potentially some side effects that may occur. Now, in asthma with beta agonists, relief medications, most of those are with frequent use and high dose, which we don't really want patients to do. But again, if you are experiencing side effects, let's communicate, let's talk about it, let's figure out what the issues and problems are, because if you decide that you're just going to stop taking the medication because it doesn't work or it makes you feel worse, we may have been able to remediate that and take a different approach. And again, you can see at the bottom, disease management is important. Managing in wellness, managing in disease exacerbation are equally important components. Stay on top of those expectations, manage and monitor relapses, progression, disease state changes, patient's ability to be adherent or not adherent, reinforce good practice and skills frequency. Sometimes we focus way too much on the negatives, things that patients aren't doing correctly, but let's pat them on the back and reward them for the things they're doing well. And if we're doing this at each and every visit, we have more opportunity to do that. And make treatment changes in collaboration with the patients. We now know that patients really would like to be involved in decision making. Again, I always like to try to bring it back to ground zero and a relevant point. This is actually from our journal that was just recently published a few weeks ago, looking at diverse inhaler devices and a big challenge for healthcare professionals. And what it basically did is repeated a study that's been done numerous times, looking at our ability to educate our patients. So if you remember about 20 minutes ago, I made the comment that I don't like putting focus on patients that are non-compliant or not adherent, because sometimes we don't provide them the tools, the education, the resources necessary to be good patients. And so this looks at our ability as healthcare clinicians to actually teach patients on how to use their inhaled medications for respiratory diseases. And what you can see here is that they took these clinicians and they gave them a written exam that everybody did very, very well on, both pre and post their intervention. They also gave them a practical exam and said, here are these devices: an Advair Discus, ProAir HFA, Pulmicort FlexHeller, and a Spiriva HandyHeller. 4 devices that actually all manage asthma, COPD, but all very different in their nature of how you activate it, how you're supposed to breathe, and how you're supposed to prep it, whatever the case may be. Very, very different mechanisms. And what you can see on here is that RTs, as well as all clinicians, improve post-intervention in their ability to do this. But interesting enough, very well documented, as in previous studies, that RTs are perhaps the best at teaching patients and knowing themselves how to use these inhaled medications. In this study, very comparable to a pharmacist, but better than a nurse and a physician. Yet when we look at the majority of patient education around devices, disease management models of these things, they're taking places by nurses, physicians, and in some cases pharmacists. Again, not demeaning those professions, they all do a great job, but it's showing that we have the knowledge, the skills, and the attributes to do patient education, disease management with these respiratory conditions and the technologies involved very, very well, and actually demonstrate that as well, or in some cases maybe a little bit better than some of our fellow healthcare clinicians. They went on to conclude that baseline written scores were significantly different across all access groups, as I originally pointed out, that the mean written scores of respiratory therapists was significantly higher than those of physicians and nurses. Baseline practical scores were significantly different again when they used the devices themselves correctly across all groups. And again, the practical score of therapists were superior. So again, this is something that we've been trained, educated, and do on a daily basis. We need to take these practices and principles and move them into that outpatient arena, if you will. Will it work? Well, again, it's nice to have data to support your concepts and your thoughts and your theories. This is a paper that was published a few years ago in 2010 in the Blue Journal, American Journal of Respiratory and Critical Care Medicine. It was a disease management program for chronic obstructive pulmonary disease, again, a randomized trial, taking patients and putting them in the normal care processes versus those in this disease management model. What they actually showed in this study of this disease management program, by the way, done by respiratory therapists, showed that the frequency of COPD-related hospitalizations and ED visits was actually lower in the disease management model than in usual care. That it had a statistically significant difference, that it showed a reduction in hospitalizations for cardiac and pulmonary conditions other than COPD by 49% of hospitals for all cause, 28%, and ED visits went down. So what's that mean graphically? When you look at this, in a combined outcome of decreased hospitalizations in emergency rooms, sometimes two outcomes kind of get lumped together to get a bigger bang for your buck. It showed a decrease in hospitalizations and emergency room visits that was statistically significant. But when you separated those two outcomes out, sometimes you don't see a difference in them when you separate them out that you do when you combine them. But interesting enough, both a decrease in hospitalization and a decrease in emergency room visits were actualized in this study when patients with COPD were put in a disease management model run by respiratory therapists. So how did they do this? They basically actually looked at starting disease management on these patients in the hospital setting, education, behavior, device instruction, coordinating care if they needed oxygen, whatever the case may be, prior to discharge. After discharge, these therapists then, by phone, intervened and called these patients in lieu of their next clinic visit to make sure everything was well, that they were not having any problems, there were no questions, and then again when they came back to the clinic they followed up. Very, very good study, and in fact when you look at some of the other outcomes that were there, they showed that actually there was not only these decreases in the acute exacerbations and the setting of care they received it, but they showed that there was statistical differences in their quality of life as reported by the St. George's Respiratory Questionnaire. So they actually felt better, and they actually had a higher quality of life for those patients in the disease management model. And in fact, they actually got prednisone with their exacerbations, and they actually got antibiotics if there was a need for antibiotics. And they showed an improvement in medication practices, be it long-term controllers or relief medications. So the model does work, and it did work by a respiratory therapist. Unfortunately, sometimes this study gets downgraded in some aspects because it was done in the VA hospital health system. I'm not trying to demean the VA hospital system, but sometimes people say, well, that is a very selective audience in a system that is built to manage across the continuum of care, and that's not the way not-for-profit or profit-based hospitals work because they're not in that captive audience, if you will. I don't buy that. I think you take the process, you meld it, you mold it, and you make it work in your setting, that these concepts and practices do work. So we talked about it and a need for therapists to move into this post-acute care landscape, if you will. Long-term growth prospects supported by strong demographic trends and significant increases in the incidence of chronic diseases is here. And it's not just being treated in the acute care setting. It's being treated in other post-acute care facilities as well as in patients' home. Therapists aren't there in enough numbers at this point in time. Advances in medical technology, clinical practice, and integrative delivery models is very important, as well as where the payers are looking to pay for this at. This is just a graphic that shows, when you look at that continuum of care, that it is impacting the patients and where they're going, that we're not just taking patients from the hospital and moving them back into the home any longer. We're hitting this continuum of care across this post-acute care facility for not only patients with trauma and brain injury and other issues, but it's also impacting where patients with COPD are sent to. As technology empowers patients to take more control of their health and healthcare, hospitals are going to downsize. They're not going to be there except for the severe cases, critical care, trauma, severe exacerbations, that we need to look at alternative sites of care. It won't happen overnight, but it is happening more and more frequently, and you're starting to see systems gravitate around this continuum of care so that they have a little bit more of a contained model, if you will, like the VA system in that previous study. And even the job data, this is from August of 2014, even the healthcare job data shows that the largest increase in healthcare clinicians is taking place in the ambulatory care setting, while we're seeing it shrink a little bit in nursing home and hospitals. So again, patients are being moved to an alternative, lower cost of care area, but some of these patients are still very, very sick and still maybe on the backside of a severe exacerbation. But RTs aren't there. Well, this is a little bit older study from the 1990s. put together by Muse and Associates that show when you put RTs in those alternative care settings or those post-acute care settings, that they could be very, very successful. This is a study that showed the benefits of RTs in skilled nursing facilities and showed that for the patients in those facilities with RTs, the patients had a 3.6 day shorter length of stay. Mortality rate went down by 42%, and the estimated Medicare cost savings were almost $100 million. So again, respiratory therapists have the knowledge, skills, and attributes to not only work in the acute care setting with acute exacerbations, trauma, critical care, but they have the ability to manage patients in that post-acute care environment. We just need to get more people to move there and work there. So as we start to wrap up here, there are other things that are coming forward, and that is things like telemedicine. And telemedicine and the RT, an item that is very, very important to us in 2015, 2016, and hopefully beyond, that we actually have legislation in the House Bill 2948, that looks at having respiratory therapists along with other allied healthcare providers, occupational therapy, physical therapy, diabetes educator, speech and language pathologist, clinicians, that will be recognized under the Medicare statutes to be reimbursed in the reimbursement model for providing telemedicine. This could be routine follow-up care, it could be post-exacerbation, and you can see by this graphic that the states now that are being Medicaid, Medicare, or both getting some reimbursement is starting to grow, and the amount of money in reimbursement in Medicare has over the last 10 years increased eightfold. So telemedicine is here to stay. It's only going to grow. The technology is making it much more feasible to do more and more, and respiratory therapists have an opportunity here if we don't let it slip through our hands. Here are two studies that have come out in the early parts of 2016 looking at telemedicine and its utility by respiratory therapists. The first one, published in Respiratory Care, looks at the ability of respiratory therapists to assess and manage ventilators remotely through telemedicine, done out of Mass General in Boston, Massachusetts, and it showed that they were pretty darn accurate in most parameters. The few parameters that they weren't able to maybe provide absolute, accurate, correlative care as those that were being done at the bedside really revolved around technology, and as the technology improves, that will improve. The second one really looks at a coaching program on adherence to continuous positive airway pressure, CPAP, for obstructive sleep apnea in the home setting. We know that, again, 60% of our patients are being non-compliant. That may be more or less in the obstructive sleep apnea arena, but again, we know that patients go home, the mask doesn't fit right, it's too tight, it's too loose, it leaks, there's too much pressure, there's not enough pressure. Whatever the case is, patients put it in a closet, they don't use their home CPAP units or whatever the case is. This was a program that was overseen by respiratory therapists that work with poly-SOMs in coaching patients through telemedicine in the home environment to get them to be more adherent, more compliant with their obstructive sleep apnea care and management, and showed a great improvement in outcomes. So again, this can be done across a variety of settings. In fact, it's an area, as I alluded to, the ARC is very involved in, has been for 20 or 30 years, will continue to be. In fact, if you look at ARC Times, I've just thrown up some headlines here, about a dozen, where we do chronic disease management, and we have a variety of articles written by experts in those areas that give us tips and hints and a lot of times data on how to run these types of programs, be it in asthma, cystic fibrosis, COPD, inpatient, outpatient, whatever the case may be. Great resource for that type of information. So to wrap up and conclude, disease management, it's a new way to approach care. It's a change in the mindset. Care will impact control of disease and symptoms as well as the quality of life. It's care that focuses on wellness and prevention regardless if a patient has a chronic condition. It moves from mandated treatment to patient-directed care across the entire healthcare continuum. As I said earlier, it's easier to give therapy than it is to educate and communicate with patients. But the ability to educate, communicate, and change behavior is absolutely vital and necessary as we move forward. I want to leave you with this report from the Pew Health Professions Commission. And it talks about linking between practice and education of the respiratory therapist. And it says the respiratory care practitioner of the future will have skills necessary to work in the acute, subacute, and long-term care settings, the entire continuum of care. Problem, because we have 75% of our folks in the acute care environment. This means that practitioners will continue to have a firm foundation in basic sciences and technology, where we're very good, but also will have the ability to do critical thinking and to do necessary patient-driven protocols. So again, the ability to take that technology and roll it into clinical practice. But we will also serve as adjuncts to physicians in the management of healthcare delivery. We will assume the role of patient education, care coordinators, and play an active role in disease management. Interesting study from the Pew Healthcare Commission. Who's heard of them? Well, it's interesting because they're almost obsolete. They've been gone for a long time. This was published in 1980, telling us this is the roadmap to the future. Yet we still only have 25% or less of our practitioners outside the acute care setting. I think we do a much better job in critical thinking skills using patient-driven protocols, but we're not using them in each and every hospital, each and every department in the U.S. We need to serve as adjuncts to physicians in the management of healthcare, just not in the acute care setting or the critical care units, but outside in the ambulatory practice. We need to do a better job and step forward as patient educators and care coordinators and practice disease management. We don't have enough people in those roles, despite the fact that it was identified over 30 years ago. So again, finalize the goals of disease management as we wrap up. Reduce the rate of disease progression, eliminating or reducing those risk factors, sustaining control of symptoms across the continuum of care, reducing recidivism or rehospitalization, facilitating active daily living in most care settings, enhancing the quality of duration of life, and ultimately prevention of continuing symptoms that impact these other areas. Areas of opportunity I think that exist for us obviously is in case or disease management, to serve as physician extenders across the continuum of care, outside the hospital wall in that post-acute care setting, through telemedicine programs, through wellness and prevention programs. We also have the ability to make impact in cardiopulmonary diagnostics, in sleep medicine, pulmonary rehab, as we start to see rehab for pulmonary patients kind of get a second wind that coincides with some of the reimbursement improvements, although it's still not great. Again, these are areas of opportunities, but we need to step forward and step into these roles and build upon our successes, documenting our outcomes, documenting improvement in patient quality of care, showing a reduction in the cost of care when we actually have patients managed by respiratory therapists in these settings and in these programs. I'm going to leave you with a final thought and a quote from John F. Kennedy, the 35th President of the United States. "Change is the law of life, and those who look only to the past or present are certain to miss the future. The future is now. The future to step up and actually improve the quality of life and the outcomes of our patient through disease management of chronic respiratory conditions is now. There are a variety of different ways to go about it. There's technology to help us, but the opportunity is now. And to sit on the sidelines and think about what we missed in the past or potentially what we can do in the future, we'll miss the opportunity that presents us today." And with that, I will stop and thank you all very much for your time and attention today.